Now, the subject that I'm covering is in your book. There's nothing that I cover that isn't. It's in the cardiovascular system. It's in actually chapter 21. And what we're about to cover right now, this is what they deal with right here. But you will see where they're talking about blood hydrostatic pressure, interstitial fluid osmotic pressure. They're doing some calculations here, and they actually have a whole picture showing these different pressures. And that's what I'm going to be explaining. Now, this is the picture that's in your book that's explaining what I'm about to, and I gave you this version. On page 232, the subject that we're dealing with on page 232 is entitled Movement of Water Across Capillary Walls. So we're obviously talking about blood capillaries. This is in the cardiovascular physiology section. And we're going to see why this is so important. So we wrote on page 232, there's actually two major factors. You'd say factors about what? About the movement of water across a capillary. There are two factors or two forces that affect whether water goes out of a capillary or into a capillary. The first factor is the capillary blood pressure. It's labeled right there, capillary blood pressure. Now that's the term I'm going to use. Your books and your future nursing books and in all the clinical books, they prefer to call it capillary hydrostatic pressure. But what capillary hydrostatic pressure means is blood pressure. All right, but I'm telling you in the book, they call it hydrostatic pressure. Now, we wrote that the normal capillary blood pressure, the blood pressure in your capillary, is about 26 millimeters of mercury. So the first thing I want to point out is this. Some of you have taken people's blood pressure, or you've had your own blood pressure taken. And the typical blood pressures you measure are something like 120 over 75, 120 over 80. Is that right? So the first point is, and we're going to explain this later in the class, you might even ask, yeah, why were there two numbers? We will explain later the reason why there's two numbers when you typically take the blood pressure is because your blood pressure actually goes up and down and up and down. We'll explain why. So they record both numbers, the higher number and the lower number, indicating how high it went and how low it went. But that's the blood pressure that you measure in an artery. The blood pressure is different in different vessels of your body. You'd say, oh my gosh, but it's true. You get different blood pressures in your capillaries and different blood pressures yet in your veins. You don't have the same blood pressure in all the different vessels of your body. We'll get to that. So the blood pressure is highest in our arteries. That's the one you usually measure. And then the blood pressure goes down as you go further away from the heart. So it's a little bit like the analogy I give is that if you have a garden hose and you turn on the water, for the garden hose, we call that water pressure. And the water pressure is higher right near the faucet than it is towards the end of the hose, where there's lower water pressure. So the further you get away from the faucet, meaning your heart, the lower that blood pressure gets. The blood pressure in our capillaries is about 26. So even though it's about up around 100 millimeters of mercury in our arteries, by the time we get to the capillaries, it's down to around 26. Now this blood pressure in our capillaries causes water to squirt out of the capillaries. You'd say, what? Our capillaries are a little bit like those garden hoses with holes in them. You ever seen the garden hoses with holes in them so you can water the lawn? So when you turn on the water pressure at the faucet, right, so the water squirts out of the hose. And obviously if you turn on more water pressure, turn on the water more, more water squirts out. If you turn on the faucet less water squirts out. So the capillaries are quite leaky or permeable. You'd say, well, wait a second, you told us they weren't. No, in fact, I told you they were leaky to everything except proteins. Water has no trouble getting across a capillary wall. All right? Proteins are too big to get out normally. All right? Now, we did learn if proteins leak out, more water follows it. We'll explain that. But normally water, whether proteins leak out or not, water has no trouble moving in or out of a capillary, across a capillary wall. So we wrote that this pressure, this capillary blood pressure or hydrostatic pressure, causes the filtration of water to squirt out of the capillary. In this picture right here, this is showing a cross-section through a capillary, and it's indicating that the blood pressure in the capillary, which can range from 32 to 12, but we're going to say 26, is causing water to squirt out. Just like the water pressure in a garden hose that has holes in it, the water pressure will cause water to squirt out of that garden hose. Okay, so that's one factor. But there's another factor, an opposing factor. Down here at the bottom of the page, my gosh, what word is there? The plasma colloid osmotic pressure. That's where that term that I just introduced to you kicks in. So that I've tried to explain where that number came from. What is it? We said the word colloid means protein. We said that because there are proteins in our blood plasma that aren't in our other extracellular fluids like tissue fluid, the osmotic pressure of blood is about 25 millimeters of mercury higher. In other words, blood plasma is more hypertonic than the other fluids of the body. And we wrote that this osmotic pressure of 25, which results from the presence of proteins in the plasma, it actually draws water into the bloodstream. You'd say it does what? Let's just look at the picture, and then we'll see it's written in a moment. In this picture on the right, it shows, here it says protein osmotic pressure, 25 millimeters of mercury. To help you visualize it, I drew some proteins. I made them green. They're not really green. You can make them any color you want. All right, so I drew some dots, some polka dots, inside spots inside the vessel. Those represent the proteins that are in the vessel and not outside the vessel. These proteins osmotically draw water into the bloodstream. You'd say, I don't get that. Let's help you visualize this a little bit better. Let's look at the handout that I gave you, this one right here. Okay, so first, let's just, in your picture, what I tried to show initially in this picture, right, let's just label the parts. These are cells. These are cells in our body. They're labeled tissue cells. They are surrounded by tissue fluid. I tried to represent, maybe not so great, that looks pretty isotonic between the tissue fluid and the intracellular fluid. And we know it is. It's perfectly isotonic. This is a capillary. This is a capillary. And up here, this is a lymphatic capillary, a lymphatic vessel. All right, let's add a few things. All right, so we've got this tissue cells, blood capillary, lymphatic capillary. Now, everywhere it's isotonic, except we know that in addition, there's some proteins that are in the blood plasma that are not in the tissue fluid. Again, I just represented those proteins that normally cannot get out of the bloodstream. The only time those proteins are able to get out of that across the capillary wall is during inflammation, under the influence of chemical mediators of inflammation, which allow the proteins out. But normally they can't get out. So I've represented these proteins by green spots, and I've labeled it plasma proteins. So that means that there's more solute particles in the blood vessel than there are out here in the tissue fluid. It's slightly hypertonic. Now, we just learned that the blood pressure in our capillaries is about how high? 26 millimeters of mercury. And that pressure inside the vessel is causing water to squirt out. So I drew some arrows indicating water squirting out. If this blood pressure increased, more water would squirt out. If this blood pressure decreased, less water would squirt out. Just like the water pressure in a garden hose, with a garden hose with holes in it. Now, the proteins osmotically draw water in. You'd say, yeah, like why? Let me remind you of a visual image we gave you before. Remember I said, what happens when you pour salt on a snail? Didn't we say that in a sense, the salt osmotically draws water out of the cells of the snail? That's what all that bubbling is when you pour salt on a snail. Haven't we learned that when sugar goes out of our bloodstream into our urine, didn't I use the expression that it, in a sense, osmotically draws water out with it? So water tends to follow the solute. So if there's more solute inside the vessel, which actually means if there's more solute, there's less water. We talked about that at the beginning of this class today. But if proportionately there's more solute, then there must be less water, because altogether you can only have so much of the two. So if there's more solute in here in the vessel than there is out here, because we've got not only the same solutes in the vessel as we do out here, but we also have proteins. So there's less water. So water actually is diffusing into the vessel down its concentration gradient. But if it helps you to visualize this easier, just imagine that these extra solute particles, these proteins, are in a sense osmotically drawing water into the vessel. Now, how big did we say this colloid osmotic pressure is? It's 25 millimeters of mercury. That's that difference in osmotic pressure that's found in the vessel due to the proteins and the blood plasma compared to the tissue fluid or the intracellular fluid. It's 25 millimeters of mercury osmotic pressure greater. So that's the force that water is being drawn into the vessel. So we see that there are two forces here. Let's return back to 232. So on page 232, in these pictures, they just show that the capillary blood pressure is causing water to squirt out, and the plasma, the presence of these proteins in the vessel are osmotically drawing water in. On the next page, 233, that's the same chart that we saw when we were doing that concentration of solutions handout earlier today, that I explained and I walked you through, and you were scratching your head saying, I don't get it. And that's where we actually saw where that colloid osmotic pressure came from. And we wrote in the middle of this page, 233, that the slightly greater total solute concentration or tonicity of the blood over the tissue fluid osmotically draws water into the bloodstream. Now, we might now ask, so what is the actual concentration of protein in the blood? We know it creates an osmotic pressure of about 25. What is the actual concentration of protein? The normal concentration of protein in your blood is 7%. That means there's 7 grams of protein in every 100 milliliters of blood. And then on this page, we have a lab form. And you've seen this form before, because we've looked at this page before. I actually told you that the protein level in the blood was 7% on page 2 of the concentration of solutions handout. And we showed you, we turned to this page, we said that according to Cook County Hospital, the normal protein level in the blood is between 6 to 8 grams of protein per 100 milliliters of blood, which is about 7 grams of protein per 100 milliliters of blood, or 7%. Where are most of these proteins in our blood made? They're made in our liver. The liver produces a number of different proteins. The major protein that it produces and secretes into the bloodstream is albumin. We mentioned that last class meeting. You'd say, I don't think so. Last class meeting, I pulled out this graduated cylinder, and I said, let's make a solution that's chemically very much like blood plasma. And we added a certain amount of salt to it, a certain amount of potassium chloride, calcium chloride, glucose, and protein. And the specific protein I told you was albumin. And remember, I even pointed out, you might have said, well, isn't albumin the protein that makes up egg whites? And I said, you're right. But I said it's also the major protein in our blood produced by our liver. Right? So that is, of the 7 grams of protein in every 100 milliliters of blood, about over 4, almost 5 of those 7 grams of protein are albumin. We wrote at the bottom of the page, most of these proteins that are in our blood are synthesized by our liver and secreted into the bloodstream. Let's look on page 234. I'm sorry, 235. On 235, we wrote exactly what I just told you. Most of the protein in our blood is albumin. Now let's turn to page 237. And on page 237, I want to look at the bottom of the page, 237. And on the bottom of 237, it says the net movement of water across the capillary wall. All right, so just before I walk you through this, let's look at our picture. And I know the art is extraordinary. All right, here's what we've learned so far. We've learned that there's a blood pressure in our capillaries of about 26 millimeters of mercury that's forcing water out. Just like water pressure in a garden hose causes water to squirt out of a hose. But we've also learned that because the blood plasma is slightly hypertonic compared to the surrounding fluids, water flows into the vessel, into the bloodstream. And the force at which water is being, in a sense, being drawn into the bloodstream is with an osmotic force or pressure of 25 millimeters of mercury. So let's see if there's a difference between these two numbers. This is the force pushing water out. This is the force drawing water in. So on page 237, the capillary blood pressure is 26 millimeters of mercury forcing water out. The COP, you would say, what's that? Colloid osmotic pressure. The osmotic pressure due to colloids. What are colloids? Proteins. Is 25 millimeters of mercury drawing water in. 26 minus 25 is 1. In which direction? Out. There's a net difference in pressure of 1 millimeter of mercury, indicating that more water goes out of the bloodstream than goes back in. Now at this point you should be basically thinking, give me a break. We're talking about 1 crummy millimeter of mercury pressure difference. Do we need to even talk about this? What this is saying, and we even wrote it right here, there's a net pressure of 1 millimeter of mercury forcing more water out of the bloodstream than going in. That means every single minute of the day, more water is going out of your bloodstream than going back in. If something doesn't compensate or correct for this, you're going to develop massive edema everywhere in your body as the water goes out of your blood vessels into your tissues, and you're going to have no fluid left in your bloodstream if something doesn't compensate for this. So what compensates for it? This excess fluid that is being forced out of the capillaries is going to be returned back to your general circulation by the entire second system of vessels in the body called the lymphatic vessels. So the whole reason why you have that entire lymphatic system of vessels is because these numbers don't balance out. The role of the lymphatic vessel is to take the excess water that's constantly squirting out and carry it back to the bloodstream. That's why you've got the lymphatic vessels. Now let's just remind you of some anatomy of where these lymphatic vessels are. So let's jump ahead to page 241. On 241, this is a review from anatomy. So on page 241, you've got lymphatic vessels everywhere in your body, essentially wherever there's blood vessels. And their role is to carry that extra fluid that's squirted out of the blood vessels and to carry that fluid back and return it back to the bloodstream. Now, we wrote, let's look at the bottom here. On the bottom, so that's what we wrote. The lymphatic vessels, the excess tissue fluid enters the lymphatic vessels, and once it enters the lymphatic vessels, it's called lymph. So once this tissue fluid enters the lymphatic vessel, we call it lymph. And all of these lymphatic vessels all over our body join together into two major lymphatic ducts. So as far as the lymphatic drainage, there is a right thoracic or right lymphatic duct. Usually we call it lymphatic, but sometimes they call it thoracic because it is in the chest. And this right lymphatic duct empties into the right subclavian vein. And it drains all the lymphatic vessels from the upper right quadrant of the body drain into this right lymphatic duct. On the next page, there is a larger left lymphatic duct. It's larger than the right. It empties into the left subclavian vein, but it drains 3/4 of the body. There, let's go back to the picture of the woman on 241. So on page 241, all of the lymphatic vessels everywhere in the body converge into two lymphatic ducts in the chest area. They're right here. They're running right alongside the vertebral column. So all of that fluid that was being collected by the lymphatic vessels empties into these two tubes. Now, the smaller one is called the right lymphatic duct, and it connects to the right subclavian vein. The larger one, the left lymphatic duct, you'd say, aren't you pointing to the wrong direction, Professor Fink? You just called this the left, isn't that on the right? We don't care about your right or left, it's your patient's left or right. You know, if the patient says, you know, this arm is really hurting me, you don't say, left arm, patient complaining of his left arm. It's your patient's, this is the left arm, all right? This is the left lymphatic duct of your patient, all right? So this larger lymphatic duct empties into the larger left, it empties into the left subclavian vein. Now, why is the left lymphatic or thoracic duct larger? Because, strangely, the lymphatic vessels from the upper right quadrant all empty into this smaller right lymphatic duct. But the lymphatic vessels from everywhere else in the body, the entire left half and lower right, all flow into this larger left lymphatic duct. All right, now we've reviewed the anatomy. Now let's really make this clinical. Let's first off looking at our picture. Looking at our picture, you'll notice that I put 3 numbers here, 1, 2, and 3. And what we're now going to look at is we're going to show you how clinically important this entire subject is. And by the time I'm done, I think we're going to be going, wow. All right? There are basically 3 major factors that create edema or dehydration. And the 3 factors are the capillary blood pressure, the plasma colloid osmotic pressure, and the lymphatic vessels. Let's go through this. First, let's go back to page 238. 238. On page 238, all right, what is edema? Edema is an excess accumulation of tissue fluid. Now, if this tissue fluid is accumulating everywhere in the body, in all the systems of the body, everywhere, it's accumulating in the digestive system and the respiratory system and the urinary system and in the muscular, everywhere in the body, it's called systemic edema. Systemic, it's everywhere, it's in all the systems. But sometimes we don't see edema everywhere. If the edema, the excess buildup of fluid, is primarily in the lungs, we call it pulmonary edema. Pulmonary meaning lungs. And then, if the edema is primarily in the abdomen, the belly, we call it abdominal edema or ascites. Has anybody ever heard that term, ascites? Now, dehydration is the exact opposite of edema. If edema is too much fluid out in the tissues, dehydration is where there's not enough fluid. It's all dried out. So there's just not enough tissue fluid, and there's drying out of the tissues. All right, now that we've defined edema and dehydration, we're going to look at those three factors. So the first of the factors is blood pressure. So let's visualizing this. If somebody's blood pressure increases, what is that going to do to the relative amount of water going out of the capillaries? It's going to increase it. So if more water is going out than normal, what's that going to result in? If more water is going out of the bloodstream into the tissues, and you're getting a buildup of tissue fluid, edema. And in fact, everybody with high blood pressure has edema. We had talked about this before. Yes, I don't think so. When we were learning about hypokalemia, and we said one of the things that can cause hypokalemia, depletion of potassium, is taking diuretics. And we said that diuretics are given to people with edema, right, to get rid of all that excess fluid. And we said, and who has edema? The edema can be caused by many things. And every person with high blood pressure, we said, has edema. And the first drugs they put them on are diuretics. Let's look at what we wrote here. Under hypertension. What does hypertension mean? High blood pressure. All right, so people who have high blood pressure not only in their arteries, but also in their capillaries and veins. So if you've got increased arterial blood pressure, so when you take their blood pressure, their arterial blood pressure is higher than normal, that means they also have higher than normal capillary blood pressure. Instead of being the normal 26, it's higher than 26. That means that more water is being filtered or squirting out of the capillaries than normal. Now, if you've got more water squirting out, but you don't have any change in the amount of water being drawn in, so more water is squirting out than normal, and you're going to develop edema. So everybody with high blood pressure has edema. Now, later we're going to learn, and you cover this in anatomy. You have two pumps to your heart. You have a right pump and a left pump. The right pump pumps blood through the lungs, the pulmonary circuit, and the left pump pumps blood through everywhere else in the body, the systemic circuit. So you can actually have high blood pressure in the pulmonary circuit, high blood pressure in the systemic circuit. You can have high blood pressure in both circuits. The more common is high blood pressure in the systemic circuit. And if you've got high blood pressure in the systemic circuit, you have what's called systemic hypertension, and that leads to systemic edema. Some people, though, have pulmonary hypertension. Has anybody ever heard that term before? Pulmonary hypertension means the high blood pressure is in their pulmonary vessels, the pulmonary circuit through the lungs, and that increased pressure just in the pulmonary capillaries causes pulmonary edema. We'll get into all that. Now, if high blood pressure leads to increased fluid or swelling, and incidentally, when people have systemic edema everywhere, because of systemic high blood pressure, where you most notice it is the ankles. And I don't know if we talked about that already, right? Because the gravity pulls it down towards the legs, the lower legs, and so you'll see these swollen ankles. All right, now if high blood pressure increases the amount of water squirting out, leading to edema, what do you think happens if somebody has a drop in their blood pressure? Now, a drop in blood pressure is called hypotension. Another word that's used for low blood pressure is shock. Now, there are many, many causes of shock or low blood pressure. Many. Just to use an example we have given you previously is anaphylactic shock, where the blood pressure drops because of a hypersensitivity or allergic reaction. And so if the arterial blood pressure drops, the blood pressure everywhere drops, including in the capillaries. Less water squirts out than normal, and it results in the opposite of edema called dehydration. Now, the second factor that we saw in our diagram is the protein levels in the blood. Which organ makes these proteins?
Liver.
The liver. So that's why we're now going to look at the liver, the effect of liver disease. So on page 239, there are many, many types of liver disorders, and I'm just going to mention a couple. The first is hepatitis. Now, in micro, you may have covered different types of hepatitis. You can have bacterial infections of the liver. You can have viral infections of the liver. In fact, in micro, you probably learned that there's at least 5 different types of, at least 4 or 5 different types of viral hepatitis. Right? They're known as hepatitis type A, type B, type C, type D. Anybody ever learn about those? And so they're all viral, but they vary primarily in their what? Mode of transmission and so on, right? So now, if somebody has an infection of their liver called hepatitis, do you think their liver functions normally if it's all infected? No. So how do you think that might affect the production of plasma proteins? Yeah, it would decrease the production or synthesis of plasma proteins because the liver is sick and the protein level in the blood would probably drop. We'll come back to that in a moment. Now, another type of liver disorder is cirrhosis of the liver. What's cirrhosis of the liver? Cirrhosis of the liver is when the liver becomes filled with fat and scar tissue. So when it becomes filled with fat and scar tissue, that's called cirrhosis of the liver. Now, in fact, there are actually a number of things that can cause the liver to become fatty and filled with scar tissue. They can cause it to become cirrhotic. But certainly the most common one that you're familiar with is people on high alcohol diets. Now, look, there's all kinds of diets. Some people are on the South Beach diet. Some people are on the Beverly Hills diet. Some are on pineapple diets, you know, and some people are on alcoholic diets, right? They start, you know, alcohol for breakfast, alcohol for lunch, right? And so it's a strict alcohol diet. Now, in terms of how does alcohol cause the liver to become all fatty and form scar tissue? So your liver, as well, I think all of you know, is commonly called the detoxification organ of the body, your detox center. Your liver breaks down or metabolizes drugs and all kinds of things, including alcohol. Now, most people, when they hear that the liver breaks down or metabolizes something, they incorrectly think that your liver takes something and turns it into nothing. That is impossible. There's a concept you should have learned in chemistry called the conservation of mass and energy. You cannot take something and turn it into nothing. Ever heard of the first law of thermodynamics, the conservation of mass and energy? So, for an example of what I'm saying. If you light a candle made out of wax, right, as the flame burns the wax, it looks like all the wax is disappearing and turning into nothing. That's impossible. When a candle is lit, the flame is converting the wax, which is an organic compound, into carbon dioxide, water vapor, and light and heat energy. If we actually added up all the carbon dioxide and the water vapor and the mass equivalent of the light and energy, it would add up to the weight of the wax. That's called the conservation of mass and energy. So when we say the liver breaks down something, it doesn't turn it into nothing, it turns it into something else. So what does the liver turn alcohol into when it metabolizes the alcohol? It turns it into fat. And you know that because, first of all, alcoholic drinks are very high in calories. They are very fattening. The higher the alcoholic content, the higher the number of calories. If you go on a diet, you can't be drinking alcohol because alcohol is really fattening. Alcohol, which I'm not asking you to remember, is C2H5OH, right? It's a 2-carbon molecule. Basically, what your liver does is it converts alcohol into acetyl coenzyme A, which is a 2-carbon molecule. Now, those acetyl sugars, we know, can be joined together into a fatty acid. We had learned that fatty acids are always a multiple of 2 in length. And just as a fatty acid can be broken apart into acetyl sugars can be joined back together into a fatty acid. when you technically, for you biochemists out there, if you break apart a fatty acid into acetyl sugars, that's called, you don't have to know this, a beta oxidation reaction. And if you join the acetyl sugars back together again into a fatty acid, it's called a reverse beta oxidation reaction. So that's how the liver converts alcohol in a bunch of fat. It forms fatty acids, and they accumulate in the liver. So as the liver gets all fatty and also forms scar tissue, it stops functioning properly. So anybody who's got cirrhosis of the liver, just as if they have hepatitis, their liver is not going to function normally. It will not be able to produce plasma proteins like normal. All right, now I'm going to add a third factor to this mix, starvation. Now, for those of you who have had a nutrition class, you actually should have learned in nutrition there are different types of starvation. You'd say, really? Yeah, the simplest type is you have nothing to eat. That's one type of starvation. But there's another type of starvation where the person actually is getting enough calories of energy in the form of carbs and fats, but they're not getting enough protein in their diet. And this goes by an African word called kwashiorkor. Have you ever heard that? So this is a protein deficiency. So in kwashiorkor, there's a deficiency of protein. So the person really just doesn't have enough protein. Now, how this relates to the liver is that in order for the liver to manufacture proteins, it makes proteins out of amino acids. And we get these amino acids from the proteins in our food. We digest the proteins into amino acids, and we absorb those amino acids into our bloodstream, and now the cells of our body, including the liver cells, can use those amino acids to join them together into human proteins, including albumin, which is a protein produced by the liver. So now let's put it all together. If somebody, for any of these three reasons I've just given you, if they have hepatitis, their liver is sick. If they have cirrhosis of the liver, their liver is damaged. If they have kwashiorkor, even though their liver is okay, it doesn't have the building blocks to make proteins. In all three cases, the liver is not able to make the proteins that it normally would. The plasma protein level drops because the liver is either damaged or sick or doesn't have the building blocks to make these plasma proteins. So if the protein level drops, what happens to this colloid osmotic pressure in the bloodstream? It drops. And if the colloid osmotic pressure drops, what does that do? That's what draws the water back into the bloodstream. So, in other words, looking at our picture, if I were to start erasing these green dots, and we had fewer and fewer of these proteins in the bloodstream, that means there's a less and less osmotic pressure to draw water back in. Now, if you have the same normal amount of water squirting out, but you've got less water being drawn in, what are you going to develop? Edema. You've got the same amount of water squirting out, but less water going back into the bloodstream. So where is it accumulating? Out in the tissues. So that leads to edema. And that's what we wrote. Now, for some reason, whenever we have edema related to liver problems, it is especially noticeable in the belly, in the abdomen. And that's called ascites. A classic example is that they have a belly filled with fluid because they don't have enough protein in their bloodstream to draw that fluid back into the bloodstream. That's what's creating this abdominal edema. So you get edema when you don't have enough proteins in the blood. All right? So that's a second factor.
But why in the belly?
It occurs everywhere. It's just for some reason, especially there because of the hepatic portal circulation and so on. That's what this picture was related to here, to remind you of the hepatic portal circulation. That's the connection between the digestive tract and the liver. But anyhow, in our diagram, so we said there were three factors. We've talked about how increasing or decreasing blood pressure can lead to edema or dehydration. We've seen how the role of proteins, if the protein level drops because of liver disease or damage or kwashiorkor, that also leads to edema. The third factor is this. What if the blood pressure's okay, the plasma protein level's okay, but we still know you still need the lymphatic vessels because there's slightly normally more fluid that squirts out than goes back in. So we need the lymphatic vessels. What if there was an obstruction, a blockage in the lymphatic vessels, so that the excess fluid that's constantly coming out of the bloodstream normally cannot be returned back to the bloodstream through the lymphatic vessels. So let me give you an example of that that's very graphic. It's on the page 240, and at page 240 we're looking at the photograph on the lower right. The photograph on the lower right. Now our first thought is, what am I looking at? Let me help you out. This is a guy's butt. His right leg doesn't look very good. This is called elephantiasis. And we describe it, and it says right here in the legend, it's the effect of stoppage of the lymphatic flow. So this, you'll notice right down here at the bottom, this is the effect of lymphatic obstruction or blockage. Now, you're not going to run into elephantiasis in the United States. But what it is it's actually a parasitic worm that multiplies. It lives and multiplies in the lymphatic vessels of the body. It's actually a tropical disease, parasitic disease, that is transmitted with a mosquito vector. Right? So just like malaria is transmitted by mosquitoes, this is a parasite, a worm. And it's, I'm not testing you on it, the name of the parasite is Wucheria bancrofti, a microfilaria nematode that multiplies in the lymphatic vessels. So what happens is, now this doesn't happen overnight. These worms are multiplying and clogging up the lymphatic vessels, and they obviously infected the leg, that leg. So therefore, we said there's constantly more fluid squirting out of the bloodstream normally than returning back in. It's okay, because normally the lymphatic vessels take that excess fluid and return it back to the bloodstream, as we've described. But what if they're not able to return that excess fluid? So this is what happens without a functioning lymphatic system. It starts to get more and more swollen, edematous. Now, this didn't happen in a week or a month. This has been going on for years. There's no reason why it should ever reach this level. There are drugs that would kill the parasitic worm. But I would say this. I've been asked over the years by students, so if somebody takes the medication and kills the worm, does this all shrink back? The answer is no. It's a little bit like, you know, when some people get really grotesquely obese, and even after they lose the weight, they got all that extra skin. This is not going to go back away. This would require, you know, a Beverly Hills plastic surgeon. There's not a lot of Beverly Hills plastic surgeons in the places in the world where you find elephantiasis. So, but that's what it would require. I want to give you one more example of a lymphatic problem. Let's look at page 247. 247. And on 247, so what we're dealing with right here on page 247 is it says, we're talking about what's known as lymphedema. Edema caused by a complication of the lymphatic vessels. And we've already mentioned elephantiasis. Let me give you one more example that you're more likely to see. Even this is not that common, but you're more likely to see than elephantiasis in this country. And that's what happens after a radical mastectomy. Now, let me just point out, about really 10, 15 years ago, when women would get breast cancer, they would do radical mastectomies. In a radical mastectomy, they would remove almost the entire breast, including the underlying lymphatic vessels in the breast. They don't usually do a radical mastectomy anymore. And that's because they've developed some newer chemotherapy, and they have greater confidence that the cancer treatment, or using these drugs, is sufficient so they don't have to be as aggressive in the surgery and the removal of parts of the body. So they're relying more on killing those cancer cells with chemotherapy. The reason why they would, in the past, remove the lymphatic vessels is because we know that cancer cells metastasize or spread through the lymphatic system. If you, unfortunately, know of somebody who's had to deal with cancer, you know that they always talk about how involved the lymph nodes are. Anybody familiar with that? Because they do a scan, and if they have breast cancer, lung cancer, whatever it might be, they want to see which lymph nodes already have cancerous cells in them, because it's spreading through the lymphatic system. So if they would, if a woman would have breast cancer in one breast, they would want to do a radical mastectomy because they knew these lymphatic vessels connect between the two breasts and it would spread to the other one. And so they wanted to make sure they removed all the cancer cells so they wouldn't metastasize or spread. Again, they don't tend to do that as much today. But when they do a radical mastectomy and they remove all the underlying lymphatic vessels, so now you don't have that drainage. And these women would always have constant swelling in the shoulder and chest area. And they always have to deal with this kind of continuous edema in the area because they don't have the lymphatic flow. Now it doesn't develop into elephantiasis because that's a worm that's multiplying and making it worse and spreading through the lymphatic vessels. This is just they remove these, that's only that. Everywhere else there are still lymphatic vessels. So it doesn't spread to other places.